I'll highlight a few of my thoughts on the glenoid bone defect. And Shekhar said that he would like me to allude to both the bony Bankart and the bone loss on the glenoid side. And these are quite often mixed. So I'm going to kind of cram two different techniques or principles within the same presentation in a 15-minute thing. So firstly, for the youngsters, for the fellows, let us make a very clear distinction between what is normal glenoid, what is bone loss, and what is bony Bankart. And I say this because I have had a couple of queries from fellows, and I have revised a couple of cases where the surgeon was relying on an MRI, went in and found a bony Bankart and quickly did a Latarjet. And so let me make this very clear that the Latarjet is for chronic bone loss and not designed to handle a fresh bony Bankart. And a fresh bony Bankart, we would do our maximum to go and do an anatomical repair and retain the fragment, and that integrates quite beautifully. So the Latarjet is not a solution for a difficult, big, or major high velocity injury as such. So having cleared that thought, then we'll proceed. The other query can be, I have often received this from my fellows, that what's a glenoid fracture and what's a bony Bankart? So anything that is secondary to chronic instability related to a throwing athlete is likely to be a bony Bankart. We're not dealing with that single episode where the first time he's had a road traffic accident and has taken the anterior column of the glenoid off. That becomes a glenoid fracture and should be treated like a glenoid fracture, because then the classification and the Eidberg and whether associated scapular injury is a completely different ballgame. So let's not go down that stream. Irrespective of whether there's a bony Bankart or a glenoid fracture, what we must understand is that fragment is rendered avascular, which means that the fragment derives its vascularity from the parent glenoid. And if you leave it like that, it is less likely to sustain and over time will shrink progressively, leading to a glenoid bone loss. So as I said, the trigger for operating a patient with a bony Bankart should be higher, your threshold should be lower, and I would go and fix them more commonly rather than the one without the bony Bankart. If you believe Sugaya's series, he says 80% of his instability patients have some form of bony fragment. And surprising where you don't see anything like this patient that you're seeing here was diagnosed as a standard Bankart. We went in and then there's a flake of bone always attached to the labrum. We would preserve this, treat it like a Bankart, but that flake of bone probably helps a better quality integration, which just means that you need a much more judicious technique of bringing that back into place as if you're reducing a fracture. I'm not sure whether it's related to a high velocity injury. It probably is in the younger individuals, but in the elderly, it's probably related to the osteoporotic bone. Try not to rely on your X-rays and MRIs for diagnosing bony Bankarts, especially if you're relying on 1 Tesla, 1.5 Tesla. The 3 Tesla images that we are now used to are very good at picking up these changes of gray shades on the MRI. Ensure you have bleeding surface. So when you have a bony Bankart, you're going to freshen both the fragment side and the glenoid side, and perhaps sometimes use dual anchors. So I see a much more preponderance of bony Bankarts in post-Bankart failures because the previous anchors present as a stress riser and the fracture line passes through them, number one. And number two, consistently, if I have an elderly lady who's had a dislocation, invariably they dislocate with a chunk of bone because of the ensuing osteoporosis. If you have a bony Bankart, your options are, if it's a big one, you can use a CC screws. That's more in tune for the glenoid fracture patients. Most of the time, you're going to treat them with an anchor. The flake that you saw with the previous video we treat it like a Bankart repair. And the ones that are rather bigger are kind of going to tilt if you use a single row Bankart. And today I would probably emphasize more on the double row technique just so that you're aware of it. Now, this is a typical, she's a 50-year-old lady, fell at home an awkward manner from a landing, and no history of dislocation, but she wouldn't allow us to touch her because she was grossly unstable. I immediately sensed that if you look closely to the anterior column, you can see something funny there. There's a double cortical shadow there. And so you do a CT scan, and a 2D CT scan shows a small flake, and you say, okay, this is undisplaced, and I could treat this conservatively. But the real giveaway is the sagittal reconstruction of the 3D reconstruction of the sagittal glenoid. And Harjoban alluded to this. I'm not sure how many of you were keen, but this is a very, very important part of his presentation, that you must ask for a 3D reconstruction with a sagittal reconstruction of glenoid, subtracting the head of humerus. Now imagine if the head of humerus is not subtracted, then you're going to miss out on this. And it might look like a very trivial fragment which is in position, likely to heal. For the glenoid bone loss, there's a very simple sign which is twice been reported as if it was reinventing the wheel. There is double cortical sign where you can see here on the X-ray in the B column on the right that it has lost its cortical shadow. Usually it's about a 20% glenoid bone loss that will lead to a positive double cortical sign. For the Bony Bankart, there is no guarantee that it will heal because it's, I think, a much more challenging surgery than a conventional Bankart. This is another patient, middle-aged, again, something funny looking, seen at the anterior glenoid. And the 3D images show a large, big triangular fragment. The fragment is thin. It is like a papad. And it's difficult to fix this with CC screws, and it's likely to shatter. And Sugaya has a bone stitcher that passes sutures through the bone. I'm not very good at this, and my worry is that I might convert it into a comminuted fragment. And so my preference is suture anchors here. And this is the 6 months post-op reconstruction. The fragments integrated beautifully. On the X-rays, you'll see metal anchors because initially this is a case from about 10 years back. Because this is osteoporotic there, you're passing the anchor through the fracture site. I was very concerned about the purchase quality strength. That's why I use metal anchors for the lateral row, and I use a peak anchor for the medial row. But now I think with the peak anchors coming in, and we have a much better quality of anchor, so we need not use metal anchors as such. This is a much more recent case, 6-7 months back. Again, if you look very closely at the X-ray, you can see there's some disruption in the cortical line, and that should be a very subtle sign, and that should alert you that I need a CT scan for this patient. In fact, this lady came in with an MRI initially. This is the actual CT scan, and you see, oh, that's okay. Looks just like a small crack in the bone. And this was an initial MRI. This is a 3 Tesla MRI, and you could see, oh, well, looks okay. And we are good to do a Bony Bankart. She's 62, and there you see that there's a fragment of bone there, or there's sometimes just a blunting of the anterior edge of the glenoid. And the actual CT is deceptive. So it's very easy to be befuddled on why is this lady so unstable. And the sagittal sections are much more revealing. So always insist on 3D. And if you don't have the resources, it's sometimes we bring the CD of the CT scan and we do the 3D reconstructions on Osiris ourselves. So she had a loose body. You could see this the view from the anterior portal that looks reasonably okay. And it looks innocent because the bony fragment is trapped underneath the labrum. But the first thing I would do is put in a double-loaded anchor with 4 sutures in there. And that has to go far more medial, far beyond the labrum. And that's tricky because you're crossing the brachial plexus while you're doing that. And the best part of the technique of using double row suturing is you don't need to pass it through the labrum or through the fragment at all. So once you've got the medial anchor, Bob's your uncle, because it's a much more easier procedure. And I'll give you the principles of that. And this is the 3-month CT scan where the fragments integrated beautifully in this patient. Just to give you the principle of this technique, let me speed up this video a little. Here you have a Bony Bankart, and the fragment is displaced medially. My idea is to come in and use the superior portal, pass in an anchor far more medial to the fracture side. This is typically going to be a double loaded 5.5 anchor. Once you've had this, then the smart thing to do is to try and get those sutures underneath on the medial side of the labrum inside that fragment. And so this is tricky because you're coming with a very, very medial portal. So you need to see the axillary nerve and then do this. Don't do this without identifying the axillary nerve. Once you've done this, then the rest bit is very tricky. You just put in two standard anchors, 2.8 or whatever you choose. Typically, we use PEEK or the bioabsorbables. And you put one of them at around 530, the other at around 230. And the idea is just to mate these. So this is the pulley technique. We use the medial suture to mate with the lateral suture without having to pass them through either of the ligament or the fragment. So here you pick up one set of sutures and you could do alternate sets as well and tie them with the one pair. And so they actually reduce the fragment and pull them in. So you're not messing around with the fragment. You kept the fragment in toto, and it actually pulls in and reduces the fragment together. The only challenge is getting that medial anchor in place without having to deal with the nerves on the medial side. So this is her final picture, and it's a very robust, very strong repair, and it obviates the question of dealing with the rough cancellous bone inside, because that is a very weak bone. So here, that's the first anchor coming in medially. That's usually a double loaded anchor. And then you have two more anchors coming in on lateral. Let's move quickly to the glenoid bone loss. As Harjuban very correctly represented there, there are enough techniques. Now, it's very nice to speak in theory about these techniques. In practice, especially in a busy practice, it's impossible to do these on your own. And then you want your radiologists who are also equally busy. And if they make errors in judgment, then it's your patient and your practice that is going to suffer. I find this fairly impractical to do all these logarithmic calculations, and I'm very calculation agnostic. So our technique is very simple. Get the data on CT scan of both shoulders and measure the widest AP diameter of the lower sector of the glenoid and compare the dimensions. And on the top, you see on the normal side is 25, on the affected side is 23. So there's just a 2 mm bone loss. And this is perfectly okay. Every millimeter bone loss equates 4% glenoid bone loss. So when you have a 5 mm bone loss, you're dealing with a 20% glenoid bone loss. The options in the presence of a bone loss are, of course, Latarjet. You could decide open arthroscopic. You could decide whether you want the Walsh classic technique with the CA ligament or the congruent arc described by Jody Beer. We won't go down that. It doesn't matter whether you do open arthroscopic or whether you do either of technique. Whatever floats your boat, you can work on those. When to use the ICBG is again another issue, and we'll deal with that. And the Bristow, I think, is pretty much historical. We don't need to go down that line. These are videos of arthroscopic Latarjet, but the same exact principles apply for the open Latarjet as well, where your graft must be adequate. It should be in the inferior sector. It has to be flush with the glenoid articulating surface, and the screws have to have a good alpha angle, which means about 15 to 20 degrees angled, so that you're perpendicular to graft, you ensure graft healing, and you're not messing around with the suprascapular nerve. At the end, because your surfaces are flush, then you've not introduced arthritis to this patient as such. And this is not easy. Whichever Latarjet you do, whether I do a open or arthroscopic, I'm challenged all the time. I think we need the maximum concentration and commitment. These are both not very easy procedures to do as such. This is an example of a 32-year-old epileptic. We had to postpone a surgery twice because she had a seizure the previous day. And so I would rarely ever do surgery for a patient who's not controlled on seizures. Now she has bilateral recurrent dislocation, extensive bone loss. If you look on the right side, she has a AP diameter, which is 23 mm, and on the left side, it's a 16 mm diameter. So that's like an excess of 30% glenoid bone loss. Now, we can't do percentage calculations, but when you're faced with a bilateral situation, we use the normal native measurement of 25 mm, and based on that, we calculate that this is 16 mm, so she's got 9 mm of glenoid bone loss. And that's extensive. And in such a case, in an epileptic, I would prefer to do iliacrest bone graft, uh, because you can get a larger graft, and in epileptics, because the conjoint is not attached, it's less likely to dislocate if it doesn't heal. If it heals, then it doesn't matter whether you've done a Latarjet or a Edin hibernate with the iliacrest bone graft. So we've done this for her. Whatever happens, whether you do a Latarjet or ICBG, at between 3 to 6 months, I beseech you to go and get a CT scan, because there is no guarantee that that graft will heal as such. So it is very important that we check, and it's a big learning curve for me also to understand what mistakes I have done. I think there are the last 3 slides left. I know I'm at 15 minutes. Um, these are 3 articles that I would like to refer to you. Number one, this is JP Warner's article, How to Do an ICBG Graft, and very nicely he's represented how to use the inner table, which is much more smoother. The other tip I would like to share from our practice is these posterior part of the iliac crest should go inferior. So you revert the graft, because then it matches identically. The curvature is actually made for each other. It's a beautiful reconstruction at the end of it. As I said, you must do your CT scans at 3 to 6 months to ensure that there's no screw problem, there's no osteolysis starting up, and the graft has integrated well. A word of caution, this is Palladini's and Poccellini's article, comparison between acute and chronic bony Bankards. Their dislocation rates after surgery were 1 case in each group, but the restoration of function was poorer in the chronic bony Bankard. So they're not the same, because the graft has shrunk, there's not enough meat on the bone. So be careful on those patients, especially if they're athletes and young people. This is the problem that I was alluding to. Unfortunately, we tend to compartmentalize everything into less than 25%, more than 25%, and such. But we are probably addressing, giving a homogeneous answer to a heterogeneous problem. You must factor in ligament laxity, whether it's a male or female, whether it's a contact athlete, and whether there's an associated heel sacs. And based on these, I will come to a decision whether to do a Latarjet. So I have done a Bankard repair for a young intern who's a female, who's not an athlete, and who has had 20% bone loss, and she's doing very well. And there's no harm in doing that. And somebody else would have done a Latarjet, and I don't think there is anything wrong between both our approaches. But it is very important not to compartmentalize everything into a very rigid zone, less than 25 and more than 25. This is a paper from Korea, Incheon, where they compared subcritical bone loss. These are all patients with less than 20% glenoid bone loss. And although they had a reasonably good result, very less failure rate, the recurrence in the Bankard group was almost 23%. The recurrence in the Latarjet group was 6.5%. So there's a difference here. So this is, if you have a young athletic population, then you would err towards doing a Latarjet. And the interesting other finding was that external rotation was more restricted in Bankard than the Latarjet. There's of course a scientific reason for that. In the end, this is a post-Latarjet. If you have an athlete or a contact athlete, they do incredibly well after Latarjet. But all these next 3 slides that I'm showing you, this is a Hind Kesari champion who's achieved his Hind Kesari 3 years after a Bankard repair. The younger guy on the bottom is a national swimmer who's achieved this after doing a Bankard repair. And this is a silver medalist at the Glasgow Commonwealth Games who've done a arthroscopic cuff repair and Bankard repair. So let's not get this message home that the Latarjet is the solution to global warming. If there is no bone loss, there should not be a Latarjet. The Bankard is equally adept at restoring function, even in contact athletes. And that's my take. If you find something deficient, if you find there's a associated large heel sacs, then go ahead and complement it with a Remplissage. But don't use Latarjet as a gun to solve all the problems related to instability. It doesn't. So in take home, last slide, bony Bankard to me is a priority. I would treat them. My threshold for operating them is much lower than a Bankard. You must be able to discern a bony Bankard versus a bone loss. Use whatever technique that suits your practice. It doesn't matter whether you do it open. I would say in my first 10 years of practice, I would do all my bony Bankards open, because that was a much robust way of doing it till I honed in my skills. And for the bone loss, you could choose coracoid, ICBG, depending on your practice. But there are a number of patients in the gray zone who are neither black or neither white. In these cases, you need to take a judicious decision based on your skills, based on your experience. Otherwise, take an opinion and then decide. And then you must always confirm post-operatively whether the graft has healed, because a graft that has not healed will have problems, complications, and then you are not appropriate for sending them to their sports. Thank you very much for your patient listening.